Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everybody, and welcome to episode number 19 of the Better Health Guy blogcast series. Today's guest is Dr. Neil Nathan, and the topic is cutting-edge medicine. Dr. Nathan is a board-certified family physician and a founding diplomat of the American Board of Holistic Medicine. From the time he began medical school at the University of Chicago's Pritzker School of Medicine, it has always been his passion to try to help as many patients as possible. He was never satisfied with sending patients home with the cliche, "Sorry, we just don't have any answers for you." In a career of more than 40 years, he's delivered babies, done surgery, and worked in the emergency room, but over the years found other disciplines that held the promise of providing more useful answers for those patients that did not respond adequately to conventional care. Over time, he found himself working mostly with patients who had not received a clear diagnosis from conventional medicine and were suffering with persistent and debilitating illnesses. These included fibromyalgia, chronic fatigue syndrome, chronic Lyme disease with its co-infections, mold illness, autism, and all varieties of chronic pain, amongst others. Dr. Neil Nathan is honored to have been the recipient of the first annual Rich Van Koninenberg Award from the Seeking Health Educational Institute conference coordinated by Dr. Ben Lynch. Dr. Nathan worked with Dr. Koninenberg in completing research on methylation chemistry and chronic fatigue syndrome and fibromyalgia, which helped to launch a profound increase in interest in this subject on an international level. He is the author of several books available on Amazon.com, including On Hope and Healing for Those Who Have Fallen Through the Medical Cracks, Healing is Possible, New Hope for Chronic Fatigue, Fibromyalgia, Persistent Pain, and Other Chronic Illnesses, and his latest, Mold and Mycotoxins, Current Evaluation and Treatment 2016, which is a personal favorite. One of the quotes that stands out for me from his work, being the type A personality that I am, is, "If some is good, more is not necessarily better." That reminded me that sometimes the body needs a nudge and not a kick. Many of his patients simply cannot take even minuscule doses of herbs or homeopathic remedies without a profound reaction, while their physicians, who may never have seen such sensitivities, diagnose them as having depression and anxiety. These reactions are not psychogenic, but are physical. He continues to develop new strategies and treatments to help these patients recover their health. And now, my interview with Dr. Neil Nathan. I am excited and honored to have Dr. Neil Nathan on the show today. For those that don't know Dr. Nathan, he's been someone that I've learned a great deal from over the years and someone that I have tremendous respect for. I'm very happy to have you on the show today, Dr. Nathan. Thank you for being here.
Thanks, Scott. Thanks for having me.
Yeah, very good. So let's start by talking a little bit about mold illness. What do you recommend in terms of testing an environment? I know in your book you talk about the mycometrics ERMI, which is the Environmental Relative Moldiness Index, and you also talk about plate testing from immunolytics. Do you generally recommend that your patients do both of those, and how do you use them in determining next steps?
Okay, there are three main ways that experts use to determine whether or not a home is safe. Generally, in the commercial end of it, they use air testing. And air testing is the worst of the three, but it is one that is most considered legal in the business. The reason it's not a good method is that it samples air from the middle of a room, and almost all the spores, if they're present, have long since dropped to the ground. So one of the well-known mold species, Stachybotrys, is the heaviest of the spores, and if it was present, it drops very quickly. So you're not going to find a lot on air testing unless that room has been stirred up, and most people don't do that when they test. So for plate testing, and they're both different. Most experts rely on ERMI because it is a bit more comprehensive and a bit more accurate. ERMI consists of PCR technology testing the dust in a room, and it tests for 36 species of molds that are known to be particularly toxic. Dr. Shoemaker has put together a shortcut for analyzing that data, which he calls the Hurts Me Too method. And that's a way to get a quick read, is this a safe house or is this not a safe house? It's not comprehensive, and looking at the full picture is actually a bit more useful. ERMI is a bit expensive, and it depends on how you do your dust sampling. Often people will vacuum the dust from a single room, and then you're not getting the whole picture of what's in that house. So I also like using the inexpensive method of plate testing, in which it's basically a petri dish with a media that grows mold. And you simply open the plate, put it on the floor of the room you're testing, let it sit exposed to air for 2 hours, and then put the top back on and you see if something grows over the next 3 to 5 days. If nothing is growing on the plates, you can be fairly comfortable. One of the benefits of plate testing for me is that you can analyze each room in your house inexpensively. The plates are only $5 a piece. And by doing that, you can perhaps get a read on, if you have mold in your home, which rooms are a problem, or where do you want to look for remediation, because some of the rooms will look fine and some of the rooms will be loaded, and that allows you to direct your attention more specifically to where you want to go to fix it.
Very good. Yeah, that's fantastic. And I know I've used both of them over the years. I know the plates were very insightful as well. And I agree that I think the full ERMI, at least in my experience, seems to present a better picture than just doing the Hurts Me Too, at least for the initial evaluation. So thanks for those comments. I know you also do some of the biotoxin illness blood tests like C4A, TGF-beta1, and really trying to kind of round out the picture of what might be happening from a perspective of mold. Another test that I know you also utilize is the RealTime Labs urine mycotoxin testing. And so I'm interested in whether you can share with our listeners how that test helps you and how it correlates then with the treatment that you do and also a patient's symptoms and their clinical presentation.
Very good question for which there is a very long answer. So hold on. When I first started doing this work, I was working with Dr. Shoemaker directly. I first flew out to Pocomoke, Maryland back in 2005 to study with Richie, and we became friends. We began to teach and lecture together. And so in my initial evaluation of mold, and I must give Richie credit for his genius in putting all of this together. In my original work, the only tests we had at that time were C4As, TGF-beta1s, MMP9s, VIPs, that alphabet soup, if you will, allowed us to some extent, clarify who was likely to have a mold illness. As work progressed, and my practice got more complicated, and so some of these comments are going to be specifically for my practice, in which, as you know, Scott, I see particularly ill patients who are very sensitive and very complicated, and I have a very high percentage of patients who have both mold and Lyme and co-infections and other things. Within that context, those tests are not as helpful, because the tests that model relies on, which are C4As and TGF-beta1s, are non-specific measures of inflammation, which are caused by mold, but they are also caused by Bartonella and Lyme. So in my patient population, I can't use that testing to differentiate which is causing what. And for that reason, I use a lot less of that. And I have gone to the real-time urine mycotoxin test as my more specific test. It's like all tests, it's still in development. We're still learning about it. But at this moment, it's the most accurate, most comprehensive test of what I'm looking for. So it's simply a urine collection, and we can go into the details of that in a minute. And from that urine, the laboratory will identify 4 families of mycotoxins. They are not a comprehensive list. There are many more, but those 4 are the most common of the mycotoxin families. And it will measure whether or not those mycotoxins are in excess. Now, the beauty of this test is, number one, if it's positive, then I'm pretty sure I'm dealing with mold. It takes the question of if a C4A or a TGF beta 1 is elevated off the table, because there may be Bartonella and there may be Lyme, but we have mold. Second, it informs me how do I want to treat this patient. In the Shoemaker model, the primary binder for all mold toxins is cholestyramine or its cousin Welchol. Now, cholestyramine is a wonderful binder for ochratoxin, but it's not a particularly good binder for 3 of the other major families, which, forgive the technical names, trichothecenes, aflatoxins, and gliotoxin. So if I have a positive ochratoxin, yes, this is someone I'll want to give cholestyramine to. But if there is no ochratoxin, but instead there's gliotoxin and or aflatoxin or trichothecene, then I need to look at other binders, which is the first step in treatment. And so the mold toxin that we find informs me of where do I want to start treatment so that I can be, from my perspective, a lot more specific about how I'm going to treat this patient. In the past, I've often found that cholestyramine works great for many patients, but it doesn't cover the whole highway. So this way I can proceed in a much more, if you will, sophisticated method.
Very good. So it's about looking at many different pieces of data, the environment, the urine testing, some of the other things that you mentioned as well, and trying to draw a conclusion about whether or not mold is an issue. And once you've come to the conclusion that mold is a factor for a given patient and they address the environment, so either moving, remediating, or whatnot, my understanding is that's always kind of the first step. Can you then kind of walk us through what you do with patients in terms of treatment?
Sure. Let me start by, there's one other benefit of the real-time test, which is, and this makes it hard for some people to fully understand it. It doesn't just measure the toxins that are in the urine. It is also a barometer of how able that person is to detoxify. Meaning, some patients are so toxic that they can barely excrete any toxin even though they're loaded. And so the first test we get from real-time is what I call the tip of the iceberg test, that I might get only a tiny bit of an excess of toxin, which is our starting point for treatment. But when I repeat the test 3 months later, I suddenly find there's massive amounts of other toxins that didn't even show up the first time. This does not mean that they're worse, necessarily. They could be re-exposed. But what it usually means is great. Now they're able to excrete these toxins, and now we're seeing what they really had in the first place. So if we understand the real-time test as a barometer of the ability to detoxify, we can make more sense out of the numbers we get.
Yeah, and that's interesting because it kind of reminds me years ago in looking at some autism-related training, and they always said that if you took a hair metals test and there was one result that showed high levels of metals and there was another child that showed no metals or very low metals, that probably the one that showed no metals in that test was the one that was really having problems excreting the metals and was the one that potentially would be more impaired from that perspective. So it sounds like that's somewhat related to what you're saying here.
It is. That's an excellent analogy, and I think it's very applicable.
Okay, great.
Okay. So to go on, to summarize very briefly, treating mold toxicity, I think of as having three components. The first we've talked about, which is you need to be sure that you are in a safe environment. And that means home, work, relatives, houses, and car. Sometimes it even means pets. So analyzing that environment is such that, yes, that is step one. One of my disagreements with Dr. Shoemaker is that he often feels that you shouldn't even begin treatment until you have addressed that relatively well. And I have observed that you can make excellent progress starting treatment even if people are in a moldy environment. It's just very difficult for many patients to immediately leave their home and family and go somewhere safe. They know they should, but there are all kinds of financial and social difficulties in immediately leaving a moldy environment. And a large percentage of my patients just can't drop everything and do it. So rather than leave them untreated, I find that it is helpful to begin the binding piece of treatment concurrent with working on getting into a mold-free environment. Okay. So having said that, we use the binders that are specific for the toxins that we find. And there's a variety of binders that are commonly used. We've mentioned cholestyramine and Welchol, but we also use chlorella, activated charcoal, bentonite clay. For gliotoxin, we use Saccharomyces and NAC. And so some combinations of these binders should really get on top of binding this material. Now, the third component of treatment, which is somewhat controversial, and again, Dr. Shoemaker is not in agreement that this is important, is the findings of Dr. Joe Brewer, in which Dr. Brewer was analyzing hundreds of his patients and realizing that many of these patients who were loaded with toxin in their urine, when he analyzed their living environment, it was clean. No ongoing exposure. And he began to kind of scratch his head and go, I mean, if you've been out of a moldy environment for years, why do you still have toxin in you? Your body would have cleared it by now. And then the light bulb went on. And although the idea is not unique to Joe, he has done some excellent research, which really makes it clear that if you've been exposed to mold and your immune system is weak, the mold may actually colonize or grow in your sinus and gut areas. And to really eradicate it, it's not enough to bind the toxin and pull it out. That will work for some patients. If your exposure to mold is brief, I spoke to a woman today who had had severe mold symptoms, and she was discovered that it was in her basement. When she left her basement and had it remediated, her symptoms improved markedly within a few weeks. Now, I don't see that in most of my patients. If you're getting better that quickly, that means to me that you probably didn't colonize, and just taking the binders is sufficient to treat you. But in my patient population, the vast majority can take binders, improve, but by testing and by symptoms, they're still toxic. And we've found that we need to add treating the sinuses with a combination of nasal sprays and treating the gut with a combination of antifungals is necessary to really eradicate it and make progress.
Very good. And for those folks listening and wanting more detail, that was very high level, but the detail is covered very well in the book that Dr. Nathan put together that is available as an ebook, less than $10 on Amazon. It's a fantastic read. I mentioned it in the intro as well. So I do highly recommend that if you want to understand more details as to the specific things that he does from a treatment perspective. So the three primary pieces are getting the environment addressed, either remediating, moving, taking the binders, and then potentially also in some patients considering the potential for colonization and addressing that as well. It sounds like those are the three main steps that you go through. If we look a little bit more at binders, because people have questions around this, when you have multiple binders that someone is taking, is it generally true that they can be taken together, or do binders also need to be separated?
It depends on the binder.
Okay.
Surprise. If you're using Saccharomyces, it's best taken with food. Saccharomyces is call it a good yeast probiotic. And it works by binding gliotoxin specifically to the cell wall and by sort of flooding the ecosystem of the gut with a good yeast, kind of pushing out both mold and candida, which also make gliotoxin. So Saccharomyces is best with food. With cholestyramine or Welchol, that's best taken a half an hour after a meal that contains some kind of fat. If we're dealing with chlorella, charcoal, or clay, those are best taken on an empty stomach between meals, ideally allowing 2 hours on either end before taking anything else. They are binders. They will bind other supplements and medications, so you want to be careful with them. You can take all of those at the same time. In fact, even as I'm talking, it should be obvious that this can become a logistical difficulty in people who already have some degree of brain fog or cognitive difficulties from their mold. And so you want to try to simplify it as much as possible. So yes, you can take most of these binders together just so you can do it and not forget.
Yeah, I would say in years of talking with people, the challenges around timing of binders is probably the thing that most people find difficult, especially when they're taking them sometimes 3 or 4 times a day, and people set their alarm for the middle of the night and all kinds of things, which can certainly be challenging. Any concerns with the long-term use of cholestyramine in terms of the impact on cholesterol, or does that not seem to be a significant issue?
I have never seen that to be an issue.
Okay.
You know, and I've probably treated a couple of thousand patients in the last couple of years, 12 years actually. I've not seen it. Yes, cholestyramine, its primary role in medicine is to lower cholesterol as a binder. Now, again, I'm working with sensitive patients, and the doses of cholestyramine that my patients take are quite a bit less than that of other practitioners. So in my patients particularly, I don't believe I've ever seen a low cholesterol caused by using it.
Okay, very good. How much of a role do you think the HLA-DR genetic predisposition ultimately plays in terms of patient outcome? Do you see that there is clinical correlation in terms of the difficulty of getting somebody well, or does it not seem to be quite as correlated as what some suggest?
You are trying to poke the bear, aren't you? Okay. So again, my opinion, and I'm happy to share that my opinion is not necessarily a majority opinion in this particular arena. Dr. Shoemaker pioneered the use of HLA-DR in helping to determine which patients were more prone to mold toxicity, or Lyme toxicity, or multiple chemical sensitivity. I've done hundreds and hundreds of those tests, and I have not seen it help me distinguish those patients who will do well with treatment from those patients who will not. Patients who have the so-called dreaded 4353 or other genetic types have done.
That would be me.
And here you are well. My point, exactly. Thank you. Patients with those genes do very well with treatment. And patients who have no genetic predisposition sometimes do poorly. So I have not found that correlation helpful.
Okay.
And keep in mind, it is a genetic potential. It doesn't mean you are locked into a genetic inability to get well. And I think people sometimes get confused with the languaging that is used around that particular issue.
Right, and I'm glad to hear that that has been your observation, because I think one of the challenges over the years, people, they see their results and somehow they then become hopeless about being able to recover, and I think that plays as much or a bigger role than the results of that test. If they don't believe they can get well, I think that in and of itself is a huge disservice. So appreciate those comments. I know there's a lot of talk recently about mycotoxins being a relatively small player in a water damaged building. So things like VOCs and microbial VOCs, or compounds created by microbes, other bacteria like mycoplasma, chlamydia, actinomyces, a bunch of other types of organisms, but also the byproducts of those organisms. And so I'm wondering, do we think that these treatment protocols also are addressing those things as well? Or is it that we're just addressing enough that the body then is able to also kind of help us in addressing some of these other things like VOCs and other bacterial exposures and things of that nature?
Okay, another good question. My opinion on this is that, first of all, thank you for stressing that mold toxicity is not merely mold itself or mold spores, but all of the other things that you've mentioned. The step one of removing a patient from that environment, I think, deals with the vast majority of those materials. VOCs and actomycins and all of those things, mannins and other chemical exposures. Merely removing exposure is probably sufficient to deal with that piece. Mycotoxins, however, set off the biotoxin pathway, a chain reaction that keeps inflammation going in the body, and that is something that has to be dealt with in this complicated method that we've been talking about this afternoon. So, yes, it is more complicated, but the basic procedure that we've talked about, I think by and large addresses most of those issues fairly comprehensively.
Perfect. Very good. And then in the Shoemaker protocol, the last step generally is VIP, or vasoactive intestinal polypeptide spray. And so I'm curious, is that something that you use in clinical practice? Do patients generally feel some improvement from it? What's your experience been?
Yes, I do use it and I do like it. I think VIP is a wonderful way to reboot the system once you've basically gotten rid of the toxins. As a general rule, and this is a bit more complicated, Dr. Shoemaker has always emphasized it won't work until you have removed the patient from a toxic environment. They're in a safe environment. You've got the toxins bound and removed from the body. Markers have been treated, and now this patient can respond to VIP. And in general, I agree completely with Dr. Shoemaker with that. However, I've had a number of patients who I thought I had completely removed the toxin from, put them on VIP, to which they responded well, and later found that no, actually it wasn't quite gone yet. A follow-up real-time test showed quite a high level, and whether that was a re-exposure or it grew back or we hadn't completely finished the job, the bottom line is I think there is a place for starting VIP earlier in the treatment, but we don't know quite exactly when that is. I don't think we have enough knowledge to know yet.
Yeah, and you brought up MARCoNS, which is a staph in the sinuses. It was interesting at the conference in Irvine at the end of last year, Mary Ackerley was talking about in people where they treated and it came back, that they're now also identifying that same organism in dental cavitations. And so it'll be interesting to see if that continues to be an issue that some people, have you seen that? Have you seen that some people needed to address maybe dental cavitations in order to clear the staph in the sinuses?
Yes, and we're seeing a number of case reports of mold and MARCoNS growing in those cavitations. And to make it a little more complicated, Aspergillus and other molds can grow in the lungs as well. So it is important to look at the whole body and the symptomatology to go, okay, what's the source of this mycotoxin? If we miss the source, we're going to be spinning our wheels.
So in patients that have both mold and Lyme disease, do you find that addressing the mold early, addressing the exposure, starting to do some binding, do you find that that generally makes the Lyme treatment either less important or less difficult? Does it tend to make things just kind of go more smoothly?
All of the above.
Okay.
To expound on that,
Sure.
simple comment. First of all, with rare exceptions, if they have both, I treat the mold first. Keeping in mind, my patient population tends to be very sensitive, and generally they're not able to treat mold and Lyme or co-infections simultaneously. A few are, but most can't do it. By can't, not won't, can't. They will overwhelm their body and they will take a turn for the worse. So generally I treat mold first. When I do, if Lyme is still under it, and I want to emphasize that, mold and Bartonella particularly are very, very similar. And clinically, it can be very difficult to distinguish them. Sometimes when we pull the mold out, what we thought was Bartonella underneath it is gone. So if you think of it as a layer which you're removing, once you get to the next layer, those symptoms will inform you to a large extent of what do I need to do next, if anything. Quite a few patients who I've worked with over the years who've been treating Lyme for a while and not getting better, once we fixed the mold, there was no Lyme underneath it. They had done a good job on the Lyme. But because of the overlap of symptoms, the treating practitioner thought, well, you still have symptoms. I guess I have to keep giving you antibiotics. And identifying mold and treating it has, for some of them, it's been, wow, maybe I'm very close to being done now.
Yeah, and it's interesting because years ago, my focus was talking about Lyme disease, and now I feel like my focus really is more talking about mold. And the reality is, looking back, I think Lyme certainly was a piece of my journey, but I think the mold was the bigger piece. Living in a place for many years that had a significant mold issue, I think everything else would have just been much easier. So I always urge people as a #1 priority, if you think that you're dealing with Lyme disease, please do everything you can to rule out mold first, because it is very, very important. Since you brought up Bartonella, I'm just curious, maybe a couple of comments on which of the Lyme-related infections or co-infections do you find the most symptom-producing for your patients and the most difficult to address?
Oh, interesting question. Which of these toxins is the worst for somebody? Gosh.
Like, are Bartonella and Babesia more challenging generally than Borrelia, or are they all pretty much on kind of a equal playing field?
They're on a fairly equal playing field. And again, it has to do with symptoms. For example, if someone was dealing with primarily joint pain with fatigue and cognitive impairment, that would lead me more to thinking about Lyme per se. That's an oversimplistic statement. If they were unusually anxious, depressed, psychologically moody, shifting, which had no correlation to stresses in their life, then Bartonella and mold would jump to my mind. You know, if they were having more shortness of breath and night sweats and pressure sensations in their head, sometimes with some psychological issues as well, then you would start thinking Babesia and so on. So I think we have to take each patient individually. The concept that one is worse than another, that's a hard one for me. In any given individual, a particular infection might be easier or harder to eradicate for reasons that I don't think we understand right now.
Okay, very good. So let's move on and talk a little bit about your new publication, the cell danger response, all of that emerging area, certainly an area that I'm interested in and understand a lot less about than mold. So I know you had a recent publication on the metabolic features of chronic fatigue syndrome. My very kind of basic understanding of this is that the body has some type of hibernation-like state or hypometabolic state. And I'm interested in what is it that we think initiates this whole process? And then after that issue is addressed, is it that the body just continues to kind of act as though it's in some type of a loop?
Yes. The cell danger response is the brainchild of a brilliant physician and researcher named Bob Navio, who I am honored to work with and to be friends with. Bob is just a delight and brilliant to boot, probably the best biochemist I've ever met. 2013, Bob summarized years of thinking about these chronic illnesses in something that he calls the cell danger response, which is a very good title. And listeners can look at the original paper, which is simply called the cell danger response. And if you Google Robert Navio, Naviaux, comma, cell danger response, that'll pop right up. You can also, by the way, pop it up by going to my website, which is www.neilnathanmd.com, and you can click right on that paper. The paper is brilliant. You will probably need to read it 4 to 10 times to extract the information that's in it. So I appreciate your comments about it's not easy to understand. But what it basically is saying is, if a cell is threatened by a toxin or by infection, it has a millennial-old way of responding to that. And it senses a toxin or an infection by a change of voltage inside the cell. It's a very specific thing. As soon as that happens, it goes through a stereotyped series of biochemical changes designed to protect the cell and to protect the organism. And yes, you could think about it as hibernation, but that isn't quite sufficient. It's more than that. It consists of, number one, shutting down the cellular chemistry to prevent the virus or bacteria from hijacking the cell's resources. A simple way to think about that would be viruses, as we know, are simply a coat of protein surrounded by nucleic acid. You could even argue whether it's alive or not. It doesn't breathe. But not arguing that, in order to replicate, it doesn't come with built-in ways of replicating it. It has to hijack methylation to reproduce itself. It has to hijack the body's various chemical components. So what the body does is it goes, I'm not going to give you that. Okay? I'm going to change the way I metabolize and make it simple. I'm going to stop making complex molecules which you need. I'm going to shut down methylation so you can't have that. And I'm going to warn neighboring cells. And if worse comes to worse, I'm going to commit hara-kiri. I'm going to kill myself so that you can't use me. And these stereotyped biochemical changes are what we call the cell danger response. It is, if you will, identical in its outcome to what is called by some the CIRS, the chronic inflammatory response syndrome, because the changes that the cell makes to do all of this sends out a series of messenger molecules, cytokines, and a big one here is purines like ATP, which is the energy molecule of the body. It sends it out to the body as a way of communicating danger. And it will keep doing that until it doesn't think it's in danger anymore. And that's where the problem comes in these inflammatory syndromes, that often the danger is past, but the cell doesn't know how to turn off the alarm. It's kind of like, I don't know, in my house, we have these smoke detectors, which if they go off, they are so loud that I can't think straight to even turn it off. And that's like what the cell is. It's almost paralyzed by its own response to this experience. So central to the cell danger response is, how do we turn this off? You know, and if you will, we mentioned VIP before, but that is one of the various substances that you can use to kind of make a change or a shift. So we're talking about a true rebooting process that has to occur to turn off this alarm, or you can't move forward.
So this is talked about in the realm of chronic fatigue syndrome. Are these characteristics and some of the outcomes the same in people with Lyme disease and fibromyalgia and other related conditions, or is this something more specific to chronic fatigue syndrome?
We're just learning the answer to that question, which is Dr. Navio has developed a wonderful mass spec assay in which he can take over 600 different biochemical materials that you can measure from a single blood draw and measure them simultaneously. With that assay, we have just begun to look at different populations of these chronic illnesses to see, are they the same or not? Now, some of this is published, and I can talk about that in more detail. Some of this is not yet published, and I can only allude to it.
Sure.
But the paper that we published, which I'm very, very proud of, is which we did this at Gordon Medical Associates with a team of doctors there and with Dr. Navio's lab at UC San Diego. And we took over 40 patients, 20 men and 20 women, with a clear diagnosis of chronic fatigue syndrome. We went to great lengths to exclude Lyme disease. It's very hard to do that perfectly, but we went to effort to do it. And you'll understand the reason why. And we compared that with the same number of controls that were sex and age matched. And it turns out there is a easily measured significant difference in the chemistry of controls and people with chronic fatigue. And this is truly a major study because, as you know, patients with chronic fatigue have been thought by many for a long time to have this in their head. This is a psychological illness, which we've known is absolutely not true. But this is the first solid proof of, no, we can measure biochemical differences in these patients. It's not in their head. It's in their chemistry. And there are a number of findings here that are worth emphasizing in our study. So, number one, we could identify women with chronic fatigue with a 96% accuracy by looking at just 13 things that were abnormally in their blood, and men with a 94% accuracy with just 6 things measured. Now, this is pretty mind-boggling. There's nothing been like this before. And unfortunately for all of you patients out there or doctors who would love to get this test and start working on it, it is not yet commercially available. It's still being standardized. We have a lot of work to do to clarify the accuracy. In fact, we have just completed a larger study working with Paul Cheney, who's been a chronic fatigue expert for years, with a larger group of patients analyzing their data. And we're just now at the data analysis state so that we can augment our findings and document it even more. I mean, this is absolutely statistically significant. I mean, this is good stuff. Also turns out that men and women have different chemistries. Men are from Mars. Women are from Venus, turns out. There's an overlap of only 25% of these abnormalities, that that by and large, there is a significant difference in the way men and women get chronic fatigue. To make it even more interesting, there's an overlap between men and women. There are about 25% of these biochemical imbalances common to everyone with chronic fatigue. And 75% have a completely unique biochemical signature. So we've been saying for a long time, you can't think of chronic fatigue syndrome as a thing. It is one biochemical imbalance. It's going to be and is a complicated analysis. So each patient will need to understand their chemistry, what's making them sick, and how do we fix it. And that's part of the beauty of this paper. It really lays it out quite nicely.
Yeah, it's absolutely amazing to see these things really starting to become more studied from a science perspective, and lots of research around chronic fatigue, and people like yourself that are really making a difference, and I anticipate even making bigger differences as more information comes to light from this work. You mentioned that the test is not yet commercially available. Is that one of the goals of Dr. Navio's work, is to come up with an assay that can be used by doctors treating these types of conditions around the world, or do you think it will remain research for the foreseeable future?
No, I think it will become commercially available before long. I think the obvious benefits and usage of this test is such that there will be pressure for this to become commercially available, I'm hoping, in the next several years. Dr. Navio is also working to develop this assay for mold, by the way, which would potentially be an even more accurate and even more comprehensive test for that. And again, we're still a year or two away from that, but we're looking at something that would be a major improvement in the accuracy of how we do it. And just to get back to your question, we have looked at, although it's not published yet, Dr. Navio has looked at Gulf War syndrome, chronic fatigue, post-traumatic stress, traumatic brain injury, and a number of other issues. All of them have a unique biochemical signature, but they are not the same signature, to answer your original question. Meaning, ultimately, we may be able to diagnostically distinguish patients by the biochemical signature that we find on this particular test. And you know how hard it is to separate these diagnoses and figure out, well, what does this patient have? I think this will be a tremendous boon for us in that regard.
Yeah, absolutely. So given we have some fingerprints or signatures that kind of tie in with specific conditions, where does that lead us to in terms of treatment? You mentioned VIP was potentially helpful. I know that Dr. Navio's earlier work, he talked about Suramin as an anti-purinergic therapy. So are there some things that are emerging maybe in the natural realm, herbs and other things that we think might be helpful for people that have these specific metabolic fingerprints, if you will?
One of Dr. Navio's many contributions is that he realized that purinergic receptors are a huge part of this stuck response. And for those of you who don't know what purinergic receptors are, the purines we're talking about are primarily ATP, the body's energy molecule. Now, when the body's healthy and well, that's how it serves. It is what delivers energy to almost every reaction in the body that requires energy. But when the cell danger response occurs, it shifts from being used in that way to it becomes a signaler of danger. And so it signals it to what are called purinergic receptors, which are simply proteins on the outside of cells that are designed to receive it. Turns out there are 19 different purinergic receptors. And one of Dr. Navio's discoveries is that Suramin, which you alluded to, is a drug that blocks all 19 receptors. So basically, it has the potential to shut off this signal, perhaps better than anything we've ever had. Very exciting. Problem is, Suramin is currently purely a research drug and virtually impossible to get. I have done some research. I've gone to some of the top herbalists in the country, asking if any of them know, Stephen Buhner among them, to asking them, do you know any herbs that are purinergic receptor blockers? And so far the answer is not yet. Now, I personally believe that the plant world can supply us with everything we need. You know, one of Buhner's main theses, and I happen to agree with that, but I don't think we know what it is yet. So
Okay.
once the importance of this subject lightens up for all of us, I think people can start beating the bushes to get these materials so that we'll have it more accessible.
Very good. Literally beating the bushes, looking for the right plants to help us get well.
Thank you for not groaning.
No, it's great. All right, so let's turn. I had another few topics here, not related to mold and not related to cell danger response, that people had an interest in your thoughts around. So how common is it that you find mast cell activation syndrome in your patients, and anything that you can share around triggers for mast cell activation? And then are you finding that while you're addressing those underlying triggers, that doing specific things to also stabilize the mast cells production of histamine is also an important aspect of your treatment approach?
You only ask questions with long answers, Scott.
Sorry.
That's okay. So first of all, for listeners, mast cells are an immune cell that is a bridge between the nervous system and the immune system. They're found in every tissue of the body, and in largest quantity in the tissues of the body, they're in close connection with the outside world. So sinus, throat, gut, rectum, vaginal area, lungs, all of the above. Their job is to react in the presence of either a toxin or an infection to coordinate the immune response. So they're, if you look under a microscope at a mast cell, it looks like this round cell studded with little teeny dots. And those dots are called granules, which are preformed molecules. And to make it complicated, mast cells can make over 200 different cell mediators or reaction mediators. The main ones in the granules, so they're available for immediate release, are histamine, serotonin, and tryptase. Histamine is the best known one. And so we've known for a number of years that mast cell activation was fairly common in our mold and Lyme patients. And we're just beginning to learn that it is even more common than we even thought. That almost all of the symptoms that mold toxicity or Lyme or Bartonella or any of these illnesses provide can be duplicated by a mast cell component. To make it worse, mast cells are triggered by mold primarily, and Lyme and Bartonella. So the very conditions we're talking about overexcite. The best way to describe a mast cell activation, it's like a hyperactive, overexcited cell which starts to react to things it's not supposed to react to. And when it does, it releases histamine. On the extreme end of it, I have seen patients have a histamine reaction to drinking water. So that's how sensitive this can be under some circumstances. And to answer your question, I would estimate that about 50% of my patients with mold toxicity have a mast cell activation component, and perhaps a somewhat smaller percentage of my Lyme patients, more common to me in Bartonella. Now that I have recognized it, and I have treated this for the last 6 or 7 years, but it was only when I read a fabulous book by Lawrence Afrin, which came out this summer, that it woke me up to, wow, this occurs in 10% of the population generally, and it's way more prevalent in my patients. I really need to be looking for it and treating it more aggressively. And so since summer, I've been really working at this pretty hard. And what I found is in my sensitive and toxic patients, if they have a mast cell component, that will add another quantum jump level of toxicity and sensitivity that I've got to address to quiet down their system so that I can even treat them. So I now address the mast cell component early on in treatment, concurrent with whatever else I want to be doing.
And is the diagnosis of mast cell activation, is that still primarily based on clinical symptoms, or are there some tests that we're finding reliably helpful for testing mast cell activation?
Symptoms are probably easier, and I wouldn't say better, but more workable. There is testing for mast cell activation. The tests are basically university-based, mildly obscure, and very difficult to get because the things that are being measured are so fleeting, so transitory in the bloodstream that if you don't catch it right as a snapshot when it's happening, you can run repeated tests which come back negative even though you have it. So it can be, to make it more complicated, it has to be drawn in a lab that has a special cold centrifuge. And if you don't do that, you'll miss it almost all the time. And very few laboratories, Quest and LabCorp don't have those centrifuges. There are only a handful of labs that are equipped to actually run these specimens properly. And even if you do, there's a very strong likelihood you'll get a negative test when you really have it. So largely, you're going to have to rely on symptoms.
And then when someone is suspected of having mast cell activation, what are some of the things that you find most helpful for stabilizing the mast cells and kind of calming their symptoms?
Well, and I'm glad you put it that way. I try to combat an activated mast cell from as many different directions as I can. So we do use mast cell stabilizers. We have both pharmaceuticals and supplements that will do both of those. And oddly, I find that patients either can work with the supplements and not the pharmaceuticals, or vice versa. So I have a kind of a startup that I use to kind of quickly answer that question. So I will put patients on quercetin as my primary mast cell stabilizer, and I will try Claritin, which is an H1 histamine blocker, and Pepcid, which is an H2 histamine blocker, early in the course of treatment. Depending on what they respond to, I'll try to stay in that arena. So I've had a few patients who've taken Claritin or Pepcid and got horribly worse. And I've had the same thing happen with quercetin, although not to the same degree. So whatever works, that's what I'm going to kind of stay with. So in the drug category, you can use sodium cromolyn, you can use ketotifen, and any of the H1 blockers. They're commonly known: Claritin, Allegra, Zyrtec, Benadryl. Again, each patient is different, and you kind of have to figure out with each. There's a lot of trial and error. And in the H2 blockers, Pepcid and Zantac are the ones that I primarily use.
So when you incorporate these and someone gets significantly worse, why do we think they get worse? I could see if they didn't get better, but what is it about these materials that makes some people worse?
Sometimes it's the filler.
Okay.
Dr. Afrin believes that the vast majority of the time, if you're reacting to a pharmaceutical, you need to have it made by a compounding pharmacy because it isn't the drug, but what comes with that drug in that product that makes the reactivity. with quercetin, for example, I found that roughly 15 to 20% of my patients have a very bad reaction to it. Sometimes GI, sometimes they get a mast cell activation from that. Now again, that could be the filler. I sometimes have found that a purer form of quercetin works, but not always. And so my final answer to that is I don't always know.
Okay, very good. So we've talked about some really exciting new areas, mast cells, cell danger response. One of the ones I haven't heard as much about recently is the lungworm from Dr. Claypow's work. And I'm wondering, is that still something we think is clinically important to explore and to treat? And if so, what are some of the things that ultimately were deemed to be useful tools in treating the lungworm?
Oh, you keep asking these complicated questions, don't you? Okay, so for listeners who are not aware of it, Dr. Larry Klapow, about 1990, we're talking about 25 years ago, in trying to figure out his own illness, which was fibromyalgia and chronic fatigue, stumbled upon a unique roundworm, which the reason he took him so many years to find it is that it was microscopic in size. It basically can't be seen by the naked eye. And he found it in the secretions that patients would cough up. So originally, it would be analyzing sputum. Later, we realized that the same worm was present in the sinuses as well, and we could obtain it more easily, by doing a nasal wash technique to look at the worm. Now, the problem with this research is it hasn't been fully confirmed by other scientists. So there are many, many, many findings that researchers doubt until some larger group of scientists all agree that this exists. Now, I have seen these worms under the microscope moving live from nasal washings. And so I don't personally doubt their existence, although there are some people who do. And they found to be uniquely present in patients with multiple chemical sensitivity. We have no research dollars, and Dr. Klapow and I have been kind of working together for years now to try to learn what we can. And I know he's very frustrated because he would really like this picked up by a larger university research group and really get to the bottom of this. But we found that in 150 patients with multiple chemical sensitivity, 95% had the worm. Now, what is particularly interesting about this is that for many years, when we've been studying patients with multiple chemical sensitivities, one of the difficulties is that when patients have that, they react virtually instantaneously to whatever they're reacting to, be it a chemical or a scent or a perfume or tobacco or whatever the reaction is. And despite that, most of the medical profession has been thinking of it as an allergy. There is no allergic process that happens that fast, to my knowledge. So one of the baffling components of this reaction is this is instantaneous. I mean, you can take one whiff and you can literally have neurological symptoms, dyskinesias, pseudo seizures, intense fatigue, brain simply goes dead on you literally within seconds of exposure. How did that happen? And in our preliminary research, some of the exciting things that we discovered was that it looks like this worm makes acetylcholinesterase, which is something that can paralyze the nervous system. And again, we have not done anywhere near the work that we need to. But finally, this makes sense, which is, if you will, multiple chemical sensitivity may represent this worm in the sinuses of patients exposed to a scent or something that they're smelling, And basically, forgive my language, the worm gets pissed off and starts making acetylcholinesterase. Now, to me, this is pretty logical. I can see that. And so I think for perhaps the first time, we have an explanation of the mechanism of how that happens. And, and it is with regret that we have not been able to get the academic world interested in this to study the worm and study how to treat it. We've only had a handful of patients accept treatment, which is totally experimental. And some of them have done a little better, but we would need a lot more. We need to know how to kill this worm, which is a fairly hard thing to do, it turns out.
Okay. Very good. So let's talk a little bit about universal reactors. So in those patients that react to almost everything that you give them, even at very low dose, what are we thinking is the underlying driver of those reactions? Is it their environment? Is it their internal level of toxicity? Is it mast cell activation, or is it something else? And then when you have someone who's so incredibly sensitive to everything, how do you get your foot in the door in those patients to be able to start treating?
Ah, yet another good question. Thank you.
You're up for the challenge.
Well, they're good questions. I like answering good questions if I can. The answer is all of the above. That's a large component, the lion's share of my patient practice. This is what I do. So my observations have been probably mold toxicity is the number one trigger. It in turn triggers mast cell activation. It can of itself create toxicity. And if we combine infections, which can be Lyme, Bartonella, viral infections of various sorts, with the toxicity that they produce, with the inflammatory response that they produce, that perfect storm creates this process. On top of that, there's an unavoidable intense anxiety in the patient, which has to be addressed as well. And that's not to say in any way that this is in someone's head, but if you are this reactive, and it's real, and unfortunately, the majority of these patients have been told by other doctors and their family that nobody can react to this. This is crazy. You just need to be taking an antidepressant and Valium or Xanax. And this bespeaks a tremendous misunderstanding of that patient, because it's unavoidable that if you are that sensitive, and this is a very real thing, I have seen patients in my clinic walk by someone who washed their clothes in Tide. They're working perfectly fine. They happen to have a reactivity to Tide and suddenly have seizures, literally fell down on the spot. And it's a reproducible event that occurs within seconds. You know, this particular patient didn't know that this person did it, but if you can react that way, walking down the street, you become understandably paranoid about every potential interaction. Any human being you pass could be wearing a scent that can throw you down the rabbit hole. And that becomes a part of the problem, which also needs to be addressed. So you have this combination of factors that creates the universal reactor. So when you get somebody that reactive, even if mold or Bartonella or something else needs to be addressed as the primary cause, you may not be able to even start treating it until you quiet that reactivity. So the first steps are, how do you quiet the reactivity? One of them for many of these patients is to address the mast cell activation, which we've talked about. Another is to address the reactivity of the brain, particularly in the area of the amygdala. So one of the programs that I love is Annie Hopper's limbic retraining, or she calls it DNRS now. For those of you who are not familiar with it, it is a series of, I will call them exercises and visualizations that specifically quiets the part of the brain that creates both the fear and the reactivity. It's a wonderful system. There's another one that's also present. I've had much fewer patients do it, by Ashok Gupta, has another program. But basically, there are no drugs involved, and with virtually no exceptions, the vast majority of patients who have needed it have benefited from this wonderfully. So I typically will start that program, a mast cell activation program, and if I believe that there is a toxicity piece that's adding to that, I'll start that as well, often by using a number of supplements. I'm particularly fond of Toxes, particularly in the form of the pediatric GL, because it's easier to titrate. And I happen to like Itiris and Renalix, which are homeopathics that help with detoxification. If it's available, I love intravenous phosphatidylcholine, that for many patients, they need to start at minuscule doses. But that is a way of healing the nervous system and helping the beginning of detoxification. And I'll often start with that before I get into treating the underlying issue.
Fantastic. Sorry, go ahead.
No, I would say that's a basic program.
Yeah, that's fantastic. Very, very helpful. I wanted to touch on viruses just for a minute. So chronic viruses like Epstein-Barr virus, HHV6, and those types of things, how important is it to address those? And then tied into that conversation, do we still think that overly supporting methylation may activate some of these viruses? So in that so many people are focused on methylation support, are we potentially actually making things worse by activating these herpes viruses that most of us probably carry?
So, two big questions in one run-on sentence. You're getting better. Okay. First of all, the viral piece, to which I will give you several answers. When I started in this field, I thought the viral piece was more important. Now, it may have been then. Our environment's changing. I'm seeing way more mold, way more Lyme, way more infections than I saw 20 years ago. So our world is becoming way more toxic, and if we don't wake up to that, we're in trouble. Having said that, as soon as an immune system is weakened by Lyme, by mold, by anything, by an emotional upheaval, by a surgical procedure, as soon as the immune system is weakened, opportunistic infections of various sorts, viruses, mycoplasma, chlamydia, can jump into the realm of, okay, everybody into the pool. The water is warm. So they can become part of the problem. Generally, I don't think they should be treated until later, if at all. And my reasoning is, so yes, you can measure elevated Epstein-Barr and HHV6 and cytomegalovirus and echoviruses. Yep, you can. But that's at a deeper level in the body. And if you fix the mold and if you fix the Lyme, the immune system will usually recover so thoroughly that now it will keep all of those in check. There's not a human being alive, you and I both. We have God knows how many potentially infectious agents in our body just waiting for our immune system to take a hit. Well, I hope not to give it the chance. But it's my immune system that keeps it at bay. So we could argue, like, can you cure Lyme? Can you cure any of these co-infections? I think so. That's my opinion. But it doesn't matter. If my immune system recovers, it will contain it, and it's as if it's not there doesn't matter from a purely practical point of view. So the vast majority of these chronic viral things don't need to be treated early, and sometimes don't need to be treated later because now the immune system is doing its job properly. Having said that, there are patients that I've treated over the years who definitely benefited from viral treatment. So no question about it. Now, to seemingly contradict myself, I've recently talked to Dr. Brewer in terms of some of our mold patients who are treading water and not improving. And what he's beginning to think, and these are preliminary observations, is that some of these have a viral piece that needs to be addressed. And so he's starting to do more viral treatments for those people who are not moving along, and he's getting some benefits of that. So wouldn't want my answer to be simple.
No, that was great. But then tying it back into some comments that you've made previously, is the reason that some people have a lower level of methylation activity an adaptation of the body to some of these viruses? And if we just start throwing in the methyl B12 and the methylfolate, is there a potential downside? Is it actually helping the viruses? Is it going against what the body was trying to do as a protective or adaptive mechanism? Or is that not something we necessarily think is still the case?
Yes and no. It depends on where you are in treatment.
Okay.
Early on, you're screwing with the adaptive response. That's not a good idea. So even if you measure methylation chemistry and it's altered, jumping in with methylation may not be what the doctor ordered. And then it's a clinical art of medicine. Okay, when is the right time? And I think you need to get a feel for that. Your patient will often give you the answer to that question. If you start a basic methylation program and they tank, they're saying, I don't think so. And particularly in mold patients and sensitive patients, often they can't start taking those materials until later in the course of treatment. No amount of folic acid or 5-methyl tetrahydrofolate or B12 can be tolerated, even minuscule doses. They will get much, much, much worse by doing that. And some practitioners don't understand it and going, oh, that means you need more. Absolutely not. That means please listen to the patient. They're saying, I can't do that now.
Right.
And so I think the piece that people don't understand is that some folks have put methylation on a pedestal to the point of, well, you have to methylate or you won't detoxify because methylation is critical to detoxification. Yes and no, which is it's not the only way to detoxify. The body has multiple ways of detoxifying, and if it can't methylate, it'll do it another way until it becomes able to do that. And so, unfortunately, I'm hearing patients freaking out because they can't take any methylation materials, and they have in their head this idea that, well, I can't possibly get well if I can't methylate, and that's not true.
Well, and this is another area where I think people oftentimes over-identify with a specific aspect of their condition. So they get their SNP testing done. They find out that they're MTHFR, CBS, COMT, all of these things. But the way I understand it is that's your potential. Those tests are not necessarily telling you whether or not those genes are expressing in that way or not. And I believe that the way you kind of look at this is not so much from the which SNPs do you have, but more functionally, what are the different levels of types of folate and other things that are happening, oxidized and reduced glutathione and so on. How's the body actually working versus just looking at the genetic potential, if I understand correctly?
Couldn't have said it better myself.
Yeah, and I think it's a really important message for people listening, because these tests are the ones that people, they oftentimes go out and get a CBS t-shirt and a COMT t-shirt and all these things. And while, it's not to say that there isn't some useful information that comes out of that. I think if you take that then and internalize it to mean that you are broken or defective or don't work properly, that message that you just sent yourself was probably more powerful than whatever the initial genetic predisposition was in the first place.
Yeah. one of the pioneers of SNP testing to measure and work with methylation is Ben Lynch, who I have great respect for and I know pretty well. And a year and a half ago at his annual symposium, and I got to give Ben great credit for this, stood up in front of the audience and said, you know, I've been telling you all to do this SNP work for methylation, and I am now convinced that it's the chemistry, and the SNPs are too complicated, too interactive. You can't determine it from the SNPs. Now, that doesn't mean that he doesn't advocate SNP testing, which he is intensely researching for a wide variety of other conditions. And I think we will find major uses for it. But it's, as you said beautifully, this is genetic potential. It does not mean that you can even know what it is doing in that body until you measure it.
Very good. Thank you. So as we wrap up, I'm interested in what is the most important thing that you do on a regular basis in support of your own health?
My way of living is I have over the years reduced to 3 basics, which is be mindful, be of service, and be grateful. And it's very difficult for any human being to live that, but I try. So I am one of the most blessed people on this planet. I have a wife who I adore and who adores me. I have a wonderful family. I have work that I love, that I am passionate about. And if you throw in some Tai Chi and regular hiking and a little Pilates, eating fairly well, honestly, I personally think that living a spiritual life is more important than any vitamin that I would ever take.
Very good. Yeah, and I know you live in a beautiful part of Northern California. From many of your past presentations that I've attended, the pictures of your backyard are pretty stellar looking. So I know you've got the connection to nature as well.
Still there.
Yeah, absolutely fantastic. This has been a really insightful conversation for me. It got my brain thinking about a lot of things. I certainly appreciate you. You know that you are one of my heroes in doing this work, not only because you're out there constantly searching and looking for answers for people that don't have other answers available to them, but really for your passion, for your empathy, for your compassion. I appreciate you, and I appreciate you being here today and sharing these thoughts with us.
Thank you, Scott. Pleasure to be here.
Thank you very much. Okay. For more information on today's guest, visit neilnathanmd.com. That's neilnathanmd.com. I appreciate your support of the Better Health Guy blogcasts series. If you'd like to follow me, you can find me on Facebook and Twitter as Better Health Guy. The show can be found on YouTube, iTunes, Google Play, and Stitcher. If you'd like to support the show, please visit betterhealthguy.com/donate. And if you'd like to be added to my newsletter, please visit betterhealthguy.com/newsletters. I'm looking forward to many more shows ahead and appreciate your interest.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.